Hello, good afternoon. So today I'll be talking on this. So this is a seventh video that I'm creating on COVID. So I'll be talking on overview of all the guidelines that have come. So as you would be aware, there's even a lot of noise with multiple guidelines that are coming out. So the first guideline I would say came from China, and after that WHO came out with their guidelines, and after that we've been getting Indian guidelines. So ICMR has come with a very brief guideline followed by Government of India. There is a guideline that is floating, but there is one comprehensive guideline which came most recently from AIMS, All India Institute of Medical Sciences. So what I've done is I've tried to really go through most of these guidelines and tried to distill out the essence of these guidelines. And there is a lot of overlap across these guidelines. And as you know, the information that is happening on COVID is quite fluidic and it is evolving in nature. So and as it evolves and as the information flows, these guidelines also tend to change. So whatever I'm talking today is as of 2nd April 2020. So these guidelines obviously over course of time would keep changing. So if you see, these are the three guidelines I've referred to. So there is a WHO guideline that came on 13th March 2020, and it says it's the second version. So I've gone through this document, and then this is the Chinese guideline that came prior to this WHO. It is also quite comprehensive, so I've gone through. So both of these would be around, this would be around some 45-page document. So WHO would be around 25 page, and this is the All India Institute of Medical Sciences guideline that came on 27th March 2020. And this is a little bit of a summary guideline, and most of the components that are incorporated in this would probably be from one of these two and maybe the Government of India guidelines. So I've gone through all these three and tried to see what is pertinent and tried to give a brief overview for most of the healthcare personnel who are dealing with COVID. So I think the first aspect of COVID which we need to know is case definition. So when do we say that a patient is possible COVID and when do we start testing them? So when you look at the definition, so any symptomatic patient who has had a travel overseas, so this remains the case definition of where they would qualify to get the COVID testing done. So if a person who has gone or who has returned overseas and manifests with any of these features, so he has temperature or he has sore throat or short of breath or cough, so any of these symptoms that exist in an individual who has come back from overseas qualifies for getting the COVID test and where the suspicion of COVID-19 would be there. So the second group is a patient who is positive. So there is a positive patient by reverse transcriptase PCR. So any symptomatic contact. So there is a contact who is a close contact of this positive patient and who becomes symptomatic. They also qualify for getting this COVID test done. Or any of the asymptomatic people. So patient, the personnel may be asymptomatic, but they are living in close proximity to this proximate patient, to this COVID-19 positive patients, and that could be healthcare worker, or it could be the same household, the family members. So they are asymptomatic, but they are in close proximity to this positive patient. Even then, they qualify to get COVID-19 testing. Or healthcare personnel who is in a close contact, who is worried that he may be exposed, would qualify for getting the COVID testing done, COVID-19 testing. So that is the second group. And the testing preferably in this asymptomatic, because they are asymptomatic, it is desirable to do the test at day 5 and day 14 to see, because two tests have to be done to completely rule out that they do not have COVID-19. So the time frame recommended is day 5 and day 14. So the third group is healthcare worker. Healthcare worker who has cared for COVID-19 patient and he is symptomatic. Any of the symptoms, he may have mild fever, fatigue, or mild sore throat or little cough. I think he would be eligible to get the COVID-19 test. So any of the healthcare personnel, it may be a nurse, doctor who manifest with any symptoms, they qualify to get the COVID-19 test. And the fourth group, which ICMR has recommended, is any of the patient with acute respiratory failure who gets admitted into the hospital. So, like in our ICU, if you have a patient with respiratory failure and you have a high index of suspicion, he does qualify to get the COVID-19. Although this may not be universally followed across India, but this is a suggestion or the guideline by ICMR where index of suspicion is high for a very critical patient who gets admitted to a hospital does qualify to get the COVID. So this is the case definition as to where you would suspect or where the patients become eligible to get the COVID-19 testing. So once the COVID-19 suspicion or suspect, so how do we triage them? So this is, I'm talking about the layout in our hospital as to how we have created, and pretty much the broader concept of how it should be managed could be derived from this, sort of a SOP that we have adopted in our hospital, which is Columbia Referral Hospital. So what we are, so if this is our hospital, this is the triage area we have created outside the hospital. It is outside the ER. So the patient who is a possible suspect of COVID or who has flu symptoms, he enters into this and he gets COVID screening done. So after this COVID screening, if they qualify as a patient who probably is not a COVID, then he enters into the ER area, which all other normal patients would be there. But if it is a strong suspicion of COVID, then they enter into the pathway which is defined for COVID pathway. So there is a track put in where they do not cross this boundary. They are transported through this pathway or through this corridor into a area which is called COVID area where COVID-19 suspects are held. And this is an area where someone is managing the patient with full personal protective equipment. So because this is a strong suspect which is identified as a suspect, and they get treated by a healthcare personnel who has donned personal protective equipment. So this is a rough guideline. So basically the flow, whatever the pathway I'm showing, is something that could be adopted where you have a screening OPD where they get screened whether they have any suspicion of COVID. If there is a strong suspicion, then they directly enter that pathway and they don't contaminate other areas and they go to the COVID-19 area where sampling is done by a personnel who is in a full personal protective equipment. So as soon as a patient is suspected, or where if someone enters with a COVID suspect, a mask has to be put on the patient. First thing you, when a patient comes for a flu OPD, I think mask has to be given upfront so that they protect themselves and they are not contaminating the area. And any personnel who is dealing with it should maintain a distance of 1 meter or 3 feet minimum. And the personnel who is approaching this patient also should have a mask. It may be a doctor, a nurse, or anyone. So they should also wear a mask and they should maintain a distance of 1 meter for clinical examination or for history taking or for taking the test, COVID-19 test or a sampling. So this is something which is recommended. So whatever I am articulating here is what is recommended in WHO guideline as well, that there should be an SOP created where they are effective triaging is done and adequate precautions is taken upfront to prevent the spread of the droplet infection. Okay, so that is a rough framework which WHO deliberates on. So then you would obviously deliberate on the clinical features. So the statistics, this is the world statistics, 87.9% of the patients with COVID-19 tend to have fever. So fever is something that is very important for us to recognize. And 13.9% of the patients can have sore throat, and 18.6% tend to have later on little short of breath, and 67.7% have cough. So this is the sort of a statistics of the clinical symptomology. And what are the other symptoms? So I'll just put it in a pictorial sense. 13.6% of the patients can have headache, and 0.8% of the patients can have conjunctival suffusion, and 5% will have nasal congestion, so they can have rhinitis, and very small percentage, 0.9%, can have hemoptysis. So fatigue is very common, so they have a lot of fatigue. 38.1% will have fatigue. Myalgia is present in 14.8%, and 3.7% can have diarrhea. ARDS is actually, this is a WHO document which says ARDS is in a reasonably small percentage, 3%. And chest X-ray abnormalities can be present in 59%, and CT abnormalities could be present up to 86%. So if you have a high index of suspicion, as we have deliberated in the previous literature also, HRCT or the CT chest appears to be very sensitive in picking up any infiltrate that may be affecting the lung, because chest X-ray you may miss around 41% of the time by in X-ray. So this is a sort of the clinical spectrum of COVID-19. And they have classified, so there is they have classified the COVID symptomology into mild, moderate, and severe, and critical. So if you look at AIMS document, it classifies as mild, moderate, severe. But if you look at Chinese document, they add in critical as another domain. So mild presentation of COVID, your X-ray may be normal and they have very mild symptoms. If it is moderate COVID-19 patients present with definitely fever, they'll have cough and sore throat or short of breath may manifest little later. That qualifies as moderate. And imaging may have some infiltrate. Some features of pneumonia may be present on chest X-ray bar CT in moderate. Severe cases, they become tachypnic. Respiratory rate goes more than 30 per minute, and their saturation, you put a pulse ox, their saturation would be less than or equal to 93%, and PaO2 by FiO2 will be less than 300. So they qualify as severe cases. And in severe cases, because they're tachypnic, you would do an imaging, and since you have a high index of suspicion, you do a CT. CT or imaging would show more than 50% progression in less than 24 to 48 hours. It means they'll be rapidly progressive with regards to the imaging findings. So if you do a CT, you would see the infiltrates getting worse within 24 to 48 hours. And so the Chinese document classifies as critical cases. The critical cases is where patient come to ICU, they get intubated, mechanically ventilated, or they may be on NIV, and they may have features of organ failure. And plus or minus, they can be in shock, they can have hypotension. This is qualified as critical cases by Chinese people. And in addition to this, the Chinese document defines once they're mechanically ventilated, they divide these critical cases into three groups. So the first group is where your respiratory system compliance is more than 30 ml per centimeter water. So then you have a moderate critical cases, if I have to call it, where respiratory system compliance is more than or equal to 15 ml with mild to moderate organ dysfunction. And the severe critical case where your compliance is less than or equal to 15 ml per centimeter with multi-organ failure. So this is the Chinese way of stratifying the critical cases. So in critical, they have three components based on compliance. So worsening compliance less than 15 qualifies as extremely critical with multi-organ failure. So if it is moderate, there is some organ dysfunction with some compromise in the respiratory compliance. Okay. So now the question comes to, when do you admit patients to to hospital basically. So this is also defined in AIMS document, WHO and Chinese document, because we need to understand when patients qualify to get admitted into hospital. So any patient who has a borderline blood pressure, systolic and diastolic less than 90/60, or who are little delirious, little confused, definitely I don't think you need a rocket science to determine that they need admission. Or if you have any patient with tachypnea whose respiratory rate is more than 30, and I think this is extremely important even in our Indian circumstance, that any patient with COVID who looks little toxic, the easiest way to screen them is to put pulse oximeter. Because once you put pulse, because most of the reports that are coming through say that they appear okay, but it is always good to just put a pulse oximeter, and if it shows saturation less than 93, it may be an indicator to identify patient who may imminently have problems and they may need admission. So the simplest thing I would suggest for anyone screening the COVID-19 or flu OPD is to just put a pulse oximeter, have a pulse oximeter, sanitize it, put a pulse oximeter and see the saturation, because that may be an early indicator to capture these patients who otherwise may become sicker. So saturation less than 93% if you identify, then it means that you can't send them home, that you need to admit them into hospital at least, not ICU per se. So then you need to identify who are at a high risk for severe disease. So anyone who is elderly, more than 60 years, with any of the problems like who is suspicious of COVID, would qualify as a high risk. Or someone who has comorbidities like hypertension or diabetes, so they also become a high risk category. Or someone with an end stage disease like you have a COPD patients with a lung disease, or you have a liver disease, or CKD patients, they all qualify. So anyone with a end organ dysfunction as a comorbidity, they become patients who are at a high risk, who can deteriorate. So you should have a low threshold for them to be admitted because they are more vulnerable and the disease may manifest in a more severe form if you miss these people. So this is to just to understand that anyone with lot of comorbidities with some organ failure on the background like CKD or COPD on a home oxygen or lung pulmonary fibrosis on a home oxygen or CLD chronic liver disease, they all qualify as high risk for severe disease. So we'll just look into some statistics as to how the disease spectrum has manifested in various countries, predominantly China. So this is a study which came in NEJM in 28th Feb 2020 by Chinese authors. So what they found is 5% of the COVID-19 patients tend to need ICU admission, and 2% of the patients would need mechanical ventilation, and the death rate was 1.4%. When you combine all of this as a composite endpoint, 6.1% qualified as being very critical, where they either need mechanical ventilation or ICU admission, or where the risk of death has been high. And if you wish to know as to what are the life-threatening issues that threaten them, ARDS, as you see, this is a study which came in Lancet on 15th Feb. So ARDS manifested in 29% of the COVID patients getting admitted to ICU, and cardiac dysfunction was present in 12%, secondary infection was present in 12%, 10% needed ICU admission, and 15% had death. So this study showed in NEJM which came 1.4. As you see here, this is the Lancet study. This showed a death rate of around 15% who get admitted to ICU, who are much sicker. So then the question that should arise in all your minds is, what are the risk factors for death? Who are the patients who are at a risk for dying when someone has COVID? So for that, this is a study which came on 9th March by Lancet, by Chinese group, where they did a multivariate regression analysis to look for what may be the risk for death. They found age is a very important risk factor. So if you have an elderly person, he is at a much higher risk of dying, because that was an odds ratio of 1.1 that was statistically significant. Or if you have a patient with higher SOFA, sequential organ failure assessment, which means if they have organ dysfunction, if they have say, liver dysfunction or acute kidney injury or hypotension, so their risk of dying is more than 5 to 5.65. The odds of dying is 5.65, which is 5 times the risk. They have a very high risk of dying. Or they have looked at D dimer, because the D dimer is a surrogate marker of cardiac dysfunction, where they found if D dimer is more than 1 microgram, it had a very high odds of identifying a patient who are at a high risk of dying. So these are the three variables that they have looked into as indicators to portend as to who may be at a much higher risk: age, organ dysfunction score being higher, and D dimer more than 1 microgram. So these three were found to be very important indicators to identify patients who are at a high risk of dying. So then you may be interested to see what were the comorbidities of these patients who got admitted into hospital. So what they found is 48% of the COVID patients who need hospital admissions had some comorbidities, and hypertension was the commonest comorbidities. 30% had hypertension, 19% had diabetes. So this was published by Zhou et al. In Lancet 9th March, and 8% had coronary artery. Again, goes on to show that people with comorbidities are at a much higher risk of getting admitted and being more sicker. That's what it shows. And this is very important. So the median duration of viral shedding, once they get infected, they continue to shed virus from the respiratory tract and from the diarrhea, from the stools, up to 20 days. So once any patient who gets infected, till 20 days he'll remain infective. He can continue to infect people, others, through his respiratory secretion, even through the feces. He'll continue to infect, he or she. And the interquartile range was 17 to 24 days. So this is the range until which they are infective, 17 to 24 days. The longest has been 37 days, which means once they get infected, they can continue to infect up to 37 days in this particular study. Which means to say, even though you have treated them with whatever antibodies and sent home, that's why we quarantine them for minimum of 14 days, because you would add 14 plus 7 as possibly asymptomatic phase and take it as it falls in that median period. That's why it's very important that they don't walk around after they have been identified, and they have to be confined to the quarantine. Otherwise, they'll continue to spread to the community. That's why social distancing is so important. because once they start moving around, they can continue to infect for up to 37 days. So this is what we have learned from the experience. And so if you all wish to know as to how they were treated by these Chinese authors, 95% of them were treated with antibiotics. 21% of these COVID-19s were treated with anti-HIV drugs, antiretroviral drugs like lopinavir and ritonavir. And 32 of the patients who were admitted into hospital needed mechanical ventilation, and 3 patients needed ECMO. But what is interesting to see is 97% of the patients who were mechanically ventilated died, and all the patients who were put on ECMO all died. So again, it's an important message. If COVID patient, we should put in as much effort to prevent them from going on to intubation mechanical, because the mortality has been found to be much higher from this Chinese study, and so is the information that is coming from other countries like Italy and USA, because mortality is definitely more than 50% even in a very good ICUs worldwide. So this is something which is important. So as much as possible, I think our efforts would be to identify these patients early, treat them early, and prevent them from down spiraling into going into mechanical ventilation or going into ICU, because the risk of death significantly increases. And what are the complications that you can expect in patients with COVID? The typical complications when they're very sick is sepsis, septic shock, ARDS, and heart failure. So these are the complications that they have noticed in patients with COVID-19. And 31% of them had developed VAP. So this is the information coming from this article which came in Lancet by Zhou et al. Okay, now we look into management. So how do we manage these COVID-19 patients? So again, management depends on mild and severe cases. If it is a mild case, you give symptomatic treatment with paracetamol, and AIMS document and WHO document, they do suggest some symptomatic relief could be provided with some cough syrups like which has dextromethorphan and other cough syrups. So symptomatic with paracetamol remains the key. So if they are very troubled with cough, some cough syrups may be helpful. And the AIMS document and WHO document and the Chinese document do suggest that one could consider treating with hydroxychloroquine. The dosage that is recommended or suggested is 400 mg twice a day on day 1, followed by 200 mg twice a day for 4 days. So this is what is recommended as a guideline from the AIMS document. And AIMS document does suggest you could add vitamin C 500 mg for 5 days as a adjunct along with hydroxychloroquine. And because there is a risk of possible secondary infection and benefit of azithromycin in addition to hydroxychloroquine, AIMS document does suggest to add azithromycin 500 mg tablets. And if there is a index of suspicion for flu, then there is a suggestion to add oseltamivir or neuraminidase inhibitor, which is Tamiflu. So you could, so these are the things that are suggested in most of the guidelines. Even Chinese guidelines does recommend that hydroxychloroquine should be added with the flu treatment, and so does the WHO document. You know? Okay, so once you have, so these are mild cases. So mild cases is where you do a swab and where swab is confirmed, but they are perfectly okay. They don't need admission. So you send them home. So you send them home by giving this treatment. You give paracetamol, HCQ, but it is very clearly suggested or recommended in all the guidelines. They should not take public transport when they are going home from the hospital. They need to be sent in a standalone ambulance or vehicle which takes them, and then it is sanitized later in the vehicle they go in. And they should go, or they should be sent with a clear instructions that they are self quarantined at home, and there should be a follow-up of these patients, that they're not roaming around. So there should be a healthcare worker who is assigned to keep a check, to keep a tab on these people whether they're really self quarantining, because the whole epidemic cannot be curtailed if this effective measure is not taken, where you send them with a clear prescription or message that they go quarantine themselves. But there should be a follow-up from healthcare department as well to make sure that they are quarantining without roaming around, because once they roam around, then the whole purpose is gone. And until when they should quarantine, definitely they should be afebrile for 72 hours and minimum of 7 days after the symptom onset, since they have become negative, or two negative samples 24 hours apart. So that is the time frame recommended in AIMS document as to self quarantine. After the symptom onset, at least 7 days or till the samples become negative 24 hours apart. So I would say 14 days is what is generally accepted. So once they come positive, 14 days they have to be quarantined, and they have to be made sure that the samples are negative. Two consecutive samples done 24 apart are negative. Okay, so that's about the mild cases. How about hospitalized cases? Patients getting admitted to hospital. So when they get admitted to hospital and if they're symptomatic, so make sure that their saturation is more than 94%, because if it's less than 94%, obviously you put them on a mask oxygen at 5 liters per minute and make sure that saturation is maintaining more than 94%. So if you are dealing with a SARI is severe acute respiratory infections. SARI, severe. So if there is a severe acute respiratory infection where they are severely hypoxemic, then you should put them on non-rebreathing oxygen or a high con mask. Put them at 10 to 15 liters per minute to achieve saturation of more than 94%. Okay. And when we give fluid resuscitation, we in severe acute respiratory infection where they are very hypoxemic, where there is a suspicion of ARDS, efforts should be taken to uh, do very cautious fluid resuscitation and be restrictive with the amount of fluids we give, because we do not want to overload them and push them into worsening respiratory failure. So this is the suggestions that comes across all the guidelines, including Chinese, WHO, AIMS document. Very restrictive with your fluid resuscitation, and resuscitate with oxygen to maintain saturation more than 94%. So if they're very sick, they need NIV, and I know there is a huge debate about the use of NIV. See, once you have identified as a potential COVID suspect, our understanding is he will be put in an isolation room with all due precautions, with personal protective equipment, and all the three guidelines suggest that a trial of NIV or HFNC, high frequency nasal cannula, could be considered based on the equipment available, expertise available, and due precautions taken. So make sure that there is a good mask interface, because once you put them on positive pressure ventilation of this sort, NIV, then there is more problem with aerosolization. So our suggestion would be, once a containment and cohorting of this patient is done effectively in an isolation room, then NIV should be initiated to obviously reduce their work of breathing, improve the oxygenation. When NIV is used, always make sure that there is a good mask interface with absolutely minimum leakage, because when there is a leakage, there is more aerosol contamination. And it is desirable to have helmet mask. The reason is because the contamination could be significantly minimized when you use a helmet mask. So I'll show you the picture of helmet mask. But whenever initiation of NIV is made, every staff should bear in mind there is increased risk of aerosolization. So it is absolutely mandatory to have a very good personal protective equipment gear in place, so that the risk to the healthcare personnel is minimized to as much as possible, or nullified to as much as possible. So if any of the unit has high frequency nasal cannula, you can initiate them on HFNC. The Chinese document clearly says if you initiate on HFNC, if they fail HFNC, it is suggested or recommended that they do not be changed from HFNC to NIV. They should straight away go for intubation. This is what Chinese documents say, but there is not much clarity in the other two guidelines, WHO, about this. So if your unit is using HFNC and you have put the patient on HFNC, if patient is failing on HFNC, then the next step would be to intubate as per Chinese document, and not to try NIV, because they've already failed HFNC. If you are put on NIV, then obviously you will see whether they're improving, which I will talk on. And once you have done this, obviously we have to send the blood cultures for all the COVID-19 patients. And after sending blood culture, you initiate on community acquired cover antibiotics, which may be guided as per your hospital policy. So along with this community acquired antibiotic as per your hospital policy, all three guidelines suggest adding oseltamivir to cover for possible influenza, because they can coexist and we do not know until the report comes, we would not know. After the report comes, you can possibly stop. And there is a suggestion or recommendation to add azithromycin also, because there are studies which have shown favorable outcome benefit by with azithromycin and hydroxychloroquine. So, and obviously once we send blood culture, we would send all the investigations. The suggested investigation is the routine investigations. You would send CBC, KFT, LFT. ABG is very important, and chest X-ray and HRCT as deemed appropriate by the treating clinician. Most importantly, get an ECG done, because we have to rule out the cardiac cause. Because once you say ARDS, obviously we have to rule out any cardiac component. So ECG and echo at the outset would be beneficial to rule out cardiac cause, and to ascertain whether there is myocardial dysfunction, which also can be a presenting problem with COVID. Because COVID, the reports have shown that it causes myocardial dysfunction. So that is something we need to have in back of mind. So these are the helmet masks. So see, when you put a mask like this, I'm afraid in India it is hard to get this helmet mask. But in the Western world, especially in Italy and UK, I think most of them are preferring to use helmet mask, because you, as you say, the contamination or aerosol contamination would be significantly minimized by using these masks. So this is how the helmet masks look. So there is no aerosolization into the environment by using these masks. So once you initiate NIV or HFNC, it is extremely important you don't leave the patient. You need to monitor. So how do you ascertain that patient is responding well to your NIV or to the HFNC that you have initiated? So you have to look at the monitor and see if your heart rate is coming down. When heart rate is coming down, then you know that patient is settling and his distress is coming down, and you will see if oxygen is improving, and you will see if blood pressure is normalizing, because when they're very distressed, there is huge sympathetic surge and they would have little hypertensive response. And you'll see if his tachypnea is settling, and you look at the saturation to see if saturations are getting better. So the crux of it is, once we initiate NIV, it becomes terribly, terribly important for the healthcare personnel to very closely monitor, observe, and regularly assess and see if patient is getting better or if patient is getting worse, because that is extremely important for a clinician to decide whether he's failing NIV and whether he would need intubation. Obviously, when you see a patient where these accessory muscles of breathing are continuing to not getting better or continuing to worsen, and there is he's getting more drowsy, or there is discoordinated muscle movements, and there is increasing short of breath, there is no comfort, then you know that it is about time that NIV is not working and he may have to be intubated. But if he is improving, if there is a good muscle coordination and short of breath is getting better, then you know NIV is helping him, and it is being beneficial. So this is something very crucial for every nursing staff who is looking after a COVID patient who's put on NIV, to ascertain whether he's getting better or he's not responding to NIV. Then you have to intubate. And it is also suggested that arterial blood gases to be monitored frequently to see whether oxygenation is improving or whether he's not retaining CO2. All these are important tools, which anyway is a part of a regular ICU rigmarole. So that is something which we need to emphasize and keep an eye on. So if they're failing NIV, then obviously the next step is intubation. So intubation in a COVID-19 patient is not like a usual intubation. So obviously there are certain other precautions that you need to take. So if your PaO2, FiO2 is less than 200, or patient is getting hemodynamically unstable, is not maintaining hemodynamic stability, then you would plan to intubate. So as you see, this is a statement made in WHO document. Endotracheal intubation should be performed by a trained and experienced provider using all the airborne precautions. So it is emphasized there should be extreme degree of vigilance, and every intubation in COVID-19 should be prepared as a difficult intubation, because you don't have room for errors here, because once you lose airway, then it becomes a crisis situation, and this crisis situation, if there is no preparation, then you would be putting other healthcare personnel into a risk if you lose out of the control. So it is very important to be very vigilant and have a clear plan as to how you would intubate, because if you see some of the Chinese videos, they had a intubating team in a COVID-19 hospital as a separate team whose only job was to go and intubate, which means they had a system in place which was a well-oiled system where this team was only doing that, which means they would be getting better and better with regards to this process. So there is an emphasis on having a clear plan when you are intubating a COVID-19 patient, because this is a patient who portends a risk for the patient himself and to all the healthcare personnel who are dealing with him. So, and if difficult or failed intubation has to be, there should be a gear prepared for this, because you don't have room for error, and there cannot be a situation where trolleys are pushed from outside to inside without a protective gear. And there should be an adequate preparation for all the gear whilst intubating this patient. So have a pro seal ready, and it is suggested that avoid bag mask, but you have to pre-oxygenate with 100% oxygen for at least 5 minutes. WHO document says at least 5 minutes. Some other documents say 3 to 5 minutes, but 5 minutes is reasonable, because they wouldn't have much reserves and they would decompensate, and have all these Giddels airways so that your ventilation is optimal. And there is a preprint publication from Australia about COVID intubation guidelines. So they do suggest two-hand vice grip whilst pre-oxygenating them. So this is taken from that preprint, pre-publication document. The whole document is on COVID-19 intubation from Australian group. So this is the layout which is been picturized in that Australian document. So they have called it as a COVID-19 airway management by Safe Airway Society, and this is the setup that they have suggested. So you have a patient, you have a COVID tray, and you have 4 people present. So there is a team leader, there is a runner, there is an airway operator and airway assistant, and outside, which is the ante room, so they have a runner. So we may not, possibly in India, we may not have this much of luxury of having so many people, but at least I would say minimum of 3 people should be there at a site for intubation, with one healthcare, one doctor who is skilled in airway outside if the inside person needs any help, who is fully donned with personal protective equipment to help him, or 2 doctors and one nurse and one help outside. I think that would be the bare minimum. And this is an Australian sort of a representation of the readiness. So they also suggest you should have a bronchoscope, airway trolley, and cardiac arrest trolley, which is only designated for COVID patients. And they have a checklist. So every unit can prepare their own checklist and see what is relevant to their unit and have this checklist. So in Colombia, we do have a checklist for intubation. We could adopt the same checklist for COVID patient as well. And this is the circuit setup that has been picturized in this document. So there is a patient, so you put them on ET tube, and between EtCO2 and ET tube, viral filter is suggested, and then that is connected to ventilator. Okay, so again there is emphasis on alternative equipment to be kept ready before intubation. So if you're dealing with a pregnant lady, obviously you will have a short stubbed endotracheal tube. So have bougies ready, and have stillets ready. So have a McCoy's blade, have Proseal, have LMA, and in the worst cases, it's always good to have all this ready, which are assigned for COVID-19 patient. And intubation, I think as you see, this cartoon doesn't show the complete gear. So you need to be in this complete gear of this nature, with goggles, with a complete personal protective equipment. So intubation has to be done with absolute precautions to make sure that you are in a full gear. So now you have intubated, how do we care? So there is a mention in all 3 documents on how do we care for ventilated patients. It is recommended only closed suction to be used for doing suctioning of intubated patient, no open section, and extreme care and vigilance has to be applied in not disconnecting the circuit at any cost. So always take efforts. So the nurses have to be absolutely vigilant in making sure that the circuits are not disconnected at any point, because as soon as it disconnects, there is a huge aerosol contamination of the environment. And it is suggested that the filter, the HME filter, and the circuits should be changed every 48 hours because of all the condensate accumulation that may be happening. And there is a guideline on how we manage the ARDS in all 3 documents: Chinese document, WHO document, and the AIMS document. And I would say, having gone through these 3 documents, there is really no difference with regards to the ARDS management. It is complying to the broad guidelines which we follow for all ARDS patients. So intermittent invasive mechanical ventilation is preferred. So you could use volume controlled ventilation or pressure controlled ventilation, but pressure controlled ventilation is more extensively studied. Low tidal volume ventilation is the way to go, and to maintain plateau pressure less than 30 centimeter of water. And if PaO2 by FiO2 is less than 200, one could consider higher PEEP strategy if the compliance is low, because we are getting reports from worldwide that in the early stages, the COVID-19 patients have normal compliance. So when they have normal compliance, so obviously then you wouldn't need a very high PEEP. So, but if you have a patient with a PaO2 FiO2 less than 200 with less compliance, then high PEEP could be considered. It's a preferred approach, but there is no studies to say that that is the only way to go. If PaO2 FiO2 is 200 to 300, then high PEEP is not beneficial. So that is something you can have in mind. So open lung ventilation plus high PEEP plus recruitment maneuver could be considered where you are pushed to the wall and you are not able to achieve normoxemia, or you have refractory hypoxemia. Recruitment maneuvers could be considered, but routine use is still to be investigated whether it's of any benefit in COVID-19 patient. So proning, I think this is extremely important, because when you look at the Chinese literature on mechanical ventilation in COVID, there's not much mention in many of the literature as to how many patients were prone with severe ARDS. But based on the experience that is coming from Italy and from the USA, so there is a recommendation that the WHO, this is a WHO statement which says that in adult patient with severe ARDS, prone ventilation is recommended. This is a WHO statement. So, and even Italian group does suggest that they do well with proning. So any COVID-19 patient who is very hypoxemic, proning has to be considered, and it is desirable to consider proning within 36 hours of severe ARDS, where you identify that severe ARDS and they would benefit from proning. And you would define severe ARDS where FiO2 is less than 150 and your FiO2 need is more than 60% with requiring PEEP more than 5. So this is a group where you would consider that early proning may be beneficial, and these are the group which you may identify who you would consider proning. And you would prone within 36 hours once all your low tidal volume ventilation with optimal PEEP and maintaining plateau pressure less than 30 is all failing. So that is when you would identify patient emergently to start proning. So that's about so all three documents, how much ever you read, that is all is the gist of ventilation. So it's just an overview, and that is not something which is new to any of the intensivists. So most of them would be very proficient in those sort of broad guidelines for ARDS and proning. So there are certain COVID-19 specific tests that one could consider. So as I said, D-dimer more than 1 microgram was considered as an independent factor for risk factor for death. So you could consider D-dimer in a COVID patient to see if it helps you to prognosticate their outcome. Ferritin levels, because there is a study which came in Lancet which showed most COVID patients who were non-survivors had a high ferritin level. LDH may be a prognostic marker, and high sensitivity cardiac troponin was high in many of the non-survivors in the document from the Chinese study. So these are COVID-19 specific tests which you could use as a surrogate markers to identify patients who have a bad outcome. And once you have intubated, and if you have to nebulize, it is recommended you don't use your conventional jet nebulizers. So metered dose inhaler through spacer or connected to the ventilator tube is what is recommended. And most all the three documents suggest that there's no role for steroids, although the Chinese document does suggest in selected patients when clinicians believe that there is a role for steroids in a patient who has a pre-existing lung disease which may benefit, it could be considered. But per se for COVID, all three documents do not recommend routine use of steroids. WHO, Chinese, and the AIMS document do not suggest routine use of steroids. So specific therapy for COVID, I think I have suggested this during mild disease: hydroxychloroquine, 400 mg twice daily on day 1, followed by 200 mg twice daily for 4 days is what is suggested. And once they are sick in ICU, so recommendation is to give lopinavir and ritonavir, HIV drugs. So 200 mg of lopinavir and 50 mg of ritonavir. And the AIMS document does suggest if you are using hydroxychloroquine with lopinavir, ritonavir, the patient, this has to be notified to ICMR. If you are using this combination, these patients have to be notified to Indian Council of Medical Research. And when you're using this combination, it is extremely important. You have to monitor ECG because they can have QT prolongation, and one needs to monitor for any patient at a risk of developing hypoglycemia. So this is something that is come as a recommendation to monitor. So that's about pretty much about the guidelines. So how much ever you read the guidelines, it encompasses on these broad sort of a variables that one needs to pay attention to. So as always, I will end with some of the videos. I think I'll just show this video.
We have an important message for all of you, especially if you live in a country that is right now facing the new coronavirus. The pandemic is growing exponentially in many countries. But the Czech Republic is one of the few in Europe that has significantly slowed down the spread of the virus. In this video, we would like to tell you what we did differently, and mainly, we would like to help you to do the same. We are following social distancing and the rules stay at home. But others do that too. We also have strict hygienic procedures. Others do that as well. But the main difference is everyone who has to leave their house has to wear a face mask. Everyone.
I know. They maybe told you that masks wouldn't protect you, but there are studies proving that even a homemade mask can be partially protective. Partially. Any protection is essential today. But now the more important thing. Masks fundamentally prevent the transmission from you to others by sneezing, coughing, but also breathing. And many people are the most contagious before they start showing symptoms. So, when we both have a face mask, I protect you, you protect me, and we are both safe.
Based on recent data, we know that population-wide use of masks is essential for suppression of the outbreak.
According to our professional experience, a simple homemade mask can prevent up to 100% of the spread of potentially infected microdroplets.
The more people use masks, the less virus can be distributed and fewer individuals are exposed.
Just a few days ago, people were laughing at those who wore masks. But some people knew about this positive effect and started to share this information across social media. The message grew fast through artists, influencers, and others. I know, face masks are in stores, right? But something incredible happened. People started making homemade masks and giving them to others for free. Many companies, theaters, and even retirement houses changed their buildings into Zoom rooms, and thousands of people started to sew masks at home. So we know that face masks work, and it has been repeatedly confirmed by scientists. We know that it is possible in just 3 days to provide face masks for 10 million people in one country. And we know that here we have fundamentally repressed the infection. Please share this knowledge and help us to change as many countries as possible. Take a picture with your face mask on and share it with the hashtag Masks for All. It can really save lives. And remember, I protect you, you protect me.
It's a video. So again, that video really emphasizes on the value of face mask, which seem to be resonating from every quarter, saying how it has flattened the curve. And I think our honorable government of India also has taken steps to make sure that everyone is wearing a mask, which may be beneficial in our country also to minimize that exponential increase. And I hear many of the cops or the police on the streets are encouraging people to wear a mask. I believe it's a good one, considering the trends in the certain countries where it is not significantly or exponentially increased. The countries like Czechoslovakia, even South Korea, Singapore, and all the eastern countries. So India, I think my message would be to consider using masks whenever you go out at this stage, and this has possibly helped us also to curtail exponential increase. So as always, I end with some of the WhatsApp images which are very interesting. So Kerala, as you see, coronavirus death 1, alcohol withdrawal 4. So dog hit by vehicle curve has flattened. So all these are humorous WhatsApp forwards we have got. See, sorry, so this is the one. I'm sure many of you would have seen these forwards. Thank you very much. So I would end with this slide where Corona is challenging our Indians about the battle. So I'm sure we are emerging victorious with whatever limitations we have in our country. So thank you very much and hope it was beneficial.